On occasion, we may have a patient who comes into our clinic, presents at the clinic with complaining of knee pain. Now, there can be a number of reasons for knee pain. It could be just because of the joint, it could be degenerative changes around the joint, or it could be because of sort of strains and stretches of the sprains of the various collateral ligaments or even the cruciate ligaments inside. But sometimes when we're coming in and we're talking about this anterior knee pain, often kind of referred to as moviegoer's knee or patellofemoral syndrome. And this is this sort of dull, sort of aching sort of pain that just doesn't seem to go away and is worse on a sort of movement after prolonged sitting or things like that. There may be a number of reasons for this. There may be a number of structures involved in this. It could be because of the sort of cartilage changes on the inner part of the patella or against the femur. There is an actual odd facet on the medial side of the patella, which actually comes in contact with the femur as the knee is flexed, usually at about 60 degrees, and that can rub and that can cause pain. So that could be a more sort of bony arthrogenic sort of cause of pain. Equally, there may be some tendinous involvement. It could be sort of quadriceps or patellar tendon becoming inflamed. There could even be some inflammation of the bursa between the tendon and the bone, and also of the fat pad around here where it has a positive Hofer sign, basically where you push on the knee and by flexing it you get a change in the sort of pain as the knee is flexed, and that's fat pad which can become inflamed. One other thing that is often missed is the neural aspect of it, which is the infrapatellar branch of the saphenous nerve, which is found medially and running down. And this can often cause pain as well because it's kind of bathed in this inflammatory fluid that's around the area and it just becomes very sensitized and uncomfortable. One way of checking it is by pushing along the nerve itself, but that could equally be other structures. Another way is to kind of take the patient lying and laterally rotate their foot, so that basically we're now stretching that nerve a little bit and then putting it into valgus stretch, which is even more stretch, and then extending the knee. So now we're getting quite a sort of tensioning or pulling on the infrapatellar branch of the saphenous nerve, and we can kind of try and change that by altering some of the elements that we put in. And that could also be a reason for anterior knee pain. Often it's a number of all of them. Quite often you would have somebody, say, with a fat pad problem that's all inflamed, uncomfortable, that's setting off the nerve, or you could have inflammatory pain because of the cartilage being inflamed, and that's setting off other structures. So all these things need to be considered when we come into treating, and then we can go on and treat and adjust and adapt our treatment accordingly. For example, sometimes taping them, and the McConnell type of taping, whereby they move the patella and unload some of the tissue there, could be quite useful because it's relieving some of the pressure or altering maybe some of the biomechanics of the patella. Equally, when we do this taping, often when we do it, we unload the skin and the tissue around here. One of the things you look for is like this little smile of the skin and the soft tissues, but that could also be unloading the infrapatellar branch of the saphenous nerve. So these are things that we can consider and looking at when we get patients coming in with anterior knee pain, not just looking at it as being a sort of arthrogenic problem coming from the patella or the cartilage of the patella, but also considering some of the other structures that may be involved, along with obviously any other contributing factors that may be involved or any trigger points or the like.